So we are starting. So good morning, everyone. Once again, this is Rolandus from Megagen, and thanks for taking the time to join this Megagen webinar. Today, we're delighted to have Dr. Sam Omar and dental technician Cristian Butnarasu as our guest speakers with a topic, the role of digital in the post-COVID-19 era, a clinician-technician approach. Dr. Sam Omar is Art2Gate and Art2Digital oral design trainer and an active member of Digital Dentistry Society. He has a private practice in Cairo, and at the same time, he is a resident in prosthetic department at Cairo University. Our second panel speaker is dental technician Cristian Butnarasu. He is a Master of Science in Biocompatible Substances, Materials, and Systems. He is specializing in CAD/CAM systems, 3D scanning and printing, and guided surgery devices. Also, he is a lecturer and trainer of guided surgery, and of course, he is a Menac Knight. As this event is live,
and a great dental technician.
Yeah, and Sam is really handsome.
I forgot to write that on the CV.
Yeah, sorry. So as this event is live, we will collect all the questions from all of the guys who are watching this, and at the end of the session, both of the speakers are going to answer the questions. So guys, the stage is yours. Please do your job.
Well, thank you so much, Rolandus, and thank you so much, Chris, for actually doing this with me. This is, you know, we've already collaborated together before, but I'm very, very happy to have Chris with me on this lecture. I think right now is the time for all of us to actually come together, and I couldn't find someone better than Chris to actually help me to deliver this message. So today our topic is called the role of digital in post-COVID era, and this is a clinician and technician approach. The reason why we chose this particular topic is because you know, I wish everybody is well right now. We're actually coming back to our practices, and we're starting to get back on track, as the guys from Megagen say. And actually, we are very excited to go back because I know most of us have had some really, really tough times, and I hope everybody right now is doing quite well. I hope you and your families are doing just fine, and we're doing well and safe. So we wanted to, you know, give out some tips and some advice on what is it exactly that we can do from now on that will probably make our practice better, and how can we be more efficient. And we'll talk about this in a lot of detail, and that's why we chose the role of digital in the post-COVID era clinician-technician approach. This is why we chose this topic. Again, right now we're living in crazy times, you know, where we have old ladies dangling puppies from the ceilings and from balconies to have them go out for a walk. And we have policemen guarding toilet paper. And we also have babies, you know, running from their mothers. So these are some of the weirdest of times that we're living in right now. And yeah, so I hope everybody's still doing fine. And let's go ahead and start. So
I think the old lady was starting to walk the dog digitally, you know, by remote walking.
Exactly, that's what's happening right now. So people are actually trying to find creative solutions just to, you know, just for them to continue with their daily tasks. So again, just the things that we'll talk about today is basically this. We'll just do a quick introduction, and then after that, we'll talk about data collection and validation for guided surgery, which data you need to collect, and how do you validate the data that you've actually collected. We'll talk about choosing the right scanning protocols for each case. We'll talk about transferring data between clinic and planning center. We'll talk about how to reduce chair time and increase your efficiency. And we'll talk about when to schedule the patients for final recall impressions and how to do this in a scientific manner and do it in a way that is absolutely efficient. And then we'll talk about smart digital tools and devices for maximum efficiency. So the way I want to start this by saying, I just want to highlight the differences between what we have been doing for the past 5 decades and those special few months that are coming our way. So all advances in dentistry for the past 50 years, for the past 5 decades, or for the sole purpose of 3 things. We've been focusing on 3 things. We want to reduce time, we want to reduce cost, and we also want to increase the quality of what we're doing. So basically that all in turn leads to an increase in profitability. And this is basically what we've been focusing on for the past 50 years. But for now, and for these few upcoming months, I think things will change and the priorities will shift a little bit. So for the upcoming months, all the concerns in dentistry will be for the sole purpose of 3 things. Reducing time, because this will never change and time is the most valuable asset. So we'll always work on reducing time, especially right now. Number 2 is reducing risk, and reducing risk for the operator and also for the patient, and increasing their safety and everybody's safety. So this is really what we're working on, and this is what we'll focus on in the upcoming few months, especially after we go back to our practices. And all these 3 things in turn lead to an increase in efficiency. And that's the word that I really want to focus on today, me and Chris, in our presentation. How can we be more efficient? Efficiency is the key word that is, we want to focus on today. So how can we be more efficient in implantology? This is the topic that I wanted to speak about today. We'll focus more in implantology today, not general planning. Let's talk about efficiency in implantology. For us to be efficient in implantology, we suggest a few things, and these are the things we'll talk about today. Number 1, digital planning. Number 2, guided surgery. These are the tools that will help you become more efficient in implantology. Number 3 would be immediate provisionalization. Number 4 would be using digital devices like ISQ. And number 5 will be using small digital tools. And all these 5 things today, we'll talk about them in detail. So, efficiency. If we talk about efficiency, we have to know that any treatment in the world goes through a few phases, or we hope that they go through these phases. Number 1, planning. So you plan your treatment, you execute your treatment, and then you follow up on the treatment. So let's talk about efficiency in planning first. How can we be efficient in planning? To be efficient in planning, I have to collect the right data. I have to know, and I have to know how to get the most diagnostic information from the collected data. Number 3 is I have to choose the right scanning protocols in order for me to be efficient in planning. So collecting the right data. In order for us to do guided surgery, any treatment planning software requires this information. It requires a CBCT scan, and it also requires a model scan. And this is what we'll talk about. So CBCT scans, for instance, not all CBCT scans work. The CBCT scans that we use for our guided surgery or for the planning they have to have some criteria. So what are these criteria that we need to have in the CBCT? So that's why we'll talk about 6 different criteria in our presentation today. We'll talk about acquisition date. We'll talk about field of view and motion artifact, metal scatter, beam hardening, and DICOM formats. So let's talk about that. Number 1, when you acquire the CBCT scan, or whenever you do planning, make sure that the CBCT scan that you're using is not older than 6 months. So let's say, for instance, you had an old scan for your patient. Make sure it's not older than 6 months if you want to use it for guided surgery. Or in some cases, when your patient comes to the office and he says, I already have a CBCT scan, and he shows you the scan, always check that the CBCT is not older than 6 months. And the reason why is being that CBCT scans need to be very recent. And the oral cavity is a very dynamic environment and changes happen. So in order for you to get the most value out of your CBCT and to get the most accuracy, make sure that it's less than 6 months old. So that's the first thing we need to check. Number 2 is field of view, FOV. Which field of view out of these 4 do we need for treatment planning for implants? We're talking about implants in this presentation. A is a full face CBCT. Do we need that to treatment plan for implants? Well, not really. Maybe if you plan diagnostic implants, maybe it's something that you could use. But generally for treatment planning implants, it's, you know, it's a little bit too big. B is a CBCT scan where you have both the upper and lower arches together. And that's something that you use whenever you have a full arch case, upper and lower. C is a quadrant scan. A quadrant CBCT scan, we only recommend using a quadrant CBCT scan only in cases where you're doing freehand surgery or if you're doing some sort of endodontics. I really recommend that you use D for guided surgery, which is a full arch CBCT scan, whether it was maxilla or mandible. The key is we want to see as much structures, as much anatomical structures in the CBCT scan, and you need to see both sides. Because besides the fact that we get more information, we also get more accurate matching. And the accuracy of the matching is of the accuracy of your guide, and that's the key to successful guided surgery. We'll also talk about motion artifacts. So what is motion artifacts? So motion artifacts is this doubling of the image that happens sometimes. So the reason why we're talking about motion artifacts is because when we acquire a CBCT scan, it takes about, you know, somewhere from 5 seconds with very fast machines all the way up to 20 seconds. During that time of the acquisition, the patient might move a little bit. And eventually when the patients move, we get things that look like this. So if you're lucky and, you know, it's very obvious, you'll get images that look something like this. In the mandible, if you check the body of the mandible where the cortical plates are, you'll find that there's this doubling right here. In the maxilla, you could check for motion artifacts in the front of the sinus, the anterior wall of the sinus, and the floor of the sinus. So why are we talking about motion artifacts is because you have to make sure that if you have a CBCT scanning machine in your office, check the CBCT scan before the patient leaves the office, because you don't want to, you don't want the patient to leave the office, and after that, when you check the CBCT scan, you'll find that there's, motion artifact in it. So you have to bring the patient back again. Just take 2 minutes of your time to go through the CBCT scan to make sure that it's free of motion artifacts. Number 4, or D, is metal scatter. And this is something that we all face. Basically, most of our patients have metal into their mouth, and that leads to really not so great images. And in my presentation today, we'll talk, me and Chris, about how we can overcome the issue of metal artifacts in detail. And this is how these metal artifacts look like. Number 5 would be beam hardening effect. And beam hardening effect is an inherent effect in the CBCT scan, which means if I have a very dense or radiopaque object in the CBCT scan, which looks very white, what happens is I usually get dark lines behind, or right next to the object. So something like this, or in these images on the right side, you see these dark streaks or dark lines behind our radiopaque object, which in reality looks like what we have on the bottom. So how does that really affect us? Well, in implantology, if you look at the case on the left side, this CBCT, if you look at the implants on the left side, you'll notice that it's, it's pitch black between the two implants. So if you look at a CBCT, you'll say maybe there is bone loss between the implants. But actually, this is not the case. You have to really understand what beam hardening is. And in order for you to follow up on implants, you have to make sure that you follow up using periapical x-rays and not CBCT scans, because periapical x-rays don't have that beam hardening effect. So the same implants that we have on the left side, now we can see them on the right side, and you find there is definitely bone between the two implants. So understanding this effect will help you make proper decisions and will prevent you from doing unnecessary treatment, especially right now.
Yeah, and I agree with everything you said, Sam. And if there is one thing that I would like to add is the CBCT files need to be exported in a multiple DICOM format. And because the CBCT machines can export also in a single format, DICOM format, then these can lead to confusion. So to identify these files, we can easily recognize them by the extension of DCM, and because they are in great numbers. That's why they call the multiple DICOM. And I think that's about it, what we can say about CBCT, and we can move on to the next requirement.
Very good. So basically, when we check the CBCT, also we have to check that, as Chris said, it's in a multiple DICOM format and we have more than one file. And now we'll talk about model scans. And Chris, could you just let us know what is it exactly the criteria that you're looking for in a model scan?
Yeah, first of all, we need to say that there are two ways to acquire the scan data. And the first way is to acquire digitally the scan data through the use of an intraoral scanner. And for a good planning, we need a full art scan, like you said before, and we need both models. Since we have to make a virtual wax-up, these two models need to be in occlusion. And a big advantage of the intraoral scanning, especially in these times, is that we can send the scan files by mail or by using other digital tools. And these can decrease the risk of cross-contamination with the laboratory. And the other way to acquire the scan data is to take a physical impression and send it to the lab, where the technician can scan the impression, or he can cast a model and then digitalize the information. Regardless of the acquisition method, both impressions need to register as much soft tissue as possible, and we don't want to have any bubbles or impression distortion because they could interfere with the sitting of the surgical guide in the patient's mouth. So high quality impressions are required, since the quality of the guide is of the quality of the model, just like any other dental procedure. So
I agree, Chris, 100%. And I think for us clinicians, we're actually used to taking impressions of teeth. But I think we always need to remember that if we're doing guided surgery, that the guides don't only seat on teeth, as you know, they seat on teeth and also soft tissue. Even though, for instance, this intraoral scan on the upper right side, it might look pretty good, but if you remember that the purpose of this particular intraoral scan is to place two implants on the upper right side and to place two molars right here, now you'll see this this intraoral scan as inadequate, and you'll find that actually we need to cover more soft tissue. So as Chris said, make sure that you have as much soft tissue coverage, whether you were taking an intraoral scan or you were taking a standard impression. Correct, Chris?
Yes, it also, because it helps us find the height of the soft tissue, the thickness.
Excellent. So let's go back to our main word today, or our keyword, which is efficiency in planning. So now we talked about collecting the right data. Let's move on to getting more diagnostic information from the collected data. So what exactly do I mean by this? So let's say, for instance, I take a CBCT scan of a patient, and then the same patient gets another CBCT scan done in a different place. Can I have more information from the CBCT scan than another scanning center place? Actually, yes, because the way we scan the patient, even though it's the same patient, we could actually get more diagnostic information by scanning the patient in a specific way. So what do I mean by this? I think some of us might have heard about this technique that is called the lip or cheek cleft technique by Dr. Scott Gans. Shout out to Dr. Scott Gans. And the technique is basically a very simple technique. Is when you're CBCT scanning the patient, just put some cotton rolls between the patient's lips and the patient's mucosa using very simple tools like cotton rolls. If you're fancy and you have a lot of Optragate in your office, you could definitely use Optragate. But just for the simple, the simple practice, just use cotton rolls, and that would really help you a lot. So if we see the CBCT scan that we have in front of us right now, because we CBCT scan the patient with the lip and cheek cleft technique, you can see this pocket right here, which allows us to push the lips of the patient away, and then it actually allows us to determine what the thickness of the soft tissue is going to be. So see here, this is a scan of a patient that was scanned normally without the lip or cheek cleft technique. And this is if we push the patient's lips or cheek away, this is basically how much information we can get. And number one, besides getting to know what the soft tissue information is and what the biotype of the patient is. It also helps us with the matching process because we have more surface to match right now. We're not only using the teeth for matching, we're also using the soft tissue.
This is the cheapest trick you can find on the market. I mean, it doesn't cost anything.
Definitely, definitely. So, you know, now that we know how to get the most diagnostic information from our CBCT scan, now let's talk about choosing the right scanning protocols. Now, without a doubt, this is one of the most important parts of our presentation today. And me and Chris will, will go through this part in a lot of detail. Choosing the right scanning protocols. Well, we have to know that we have different types of cases and we don't treat all the patients exactly the same way. Because you don't treat all the patients the same way, it doesn't really make a lot of sense if we scan all the patients the same way. So what we need to know is we need to know what is the right way to scan each different type of case. So with that in mind, let's talk about the two different types of cases that we have. We have the standard partially edentulous case where the patient has most of their teeth and they're missing just a few teeth. This is one type of case. And the second type is a fully edentulous patient. This is a patient that does not have any teeth. First, we'll talk about a partially edentulous case. This is a very simple case, and this is the easiest case that you can get in your office. The reason why is because the workflow is, quite simple. So the way the workflow works is that we get the CBCT scan of the patient, we get a model of the patient, and then we go ahead and we merge both of them together. This is just a standard procedure that everybody knows. But because we need to always remember that the patients, when they come to our office, they're looking for teeth, we have to always plan the implants based on the prosthetic position. So we always do the wax up first, and then the last step will be to treatment plan the implant position. And that's the key for you to get what we call the top-down treatment planning concept or the restoratively driven planning. And that's a very, very, very important part. So that's, when it comes to partially edentulous cases, again, they're very simple and it's very easy to get the matching. The reason why it's very simple is because in the CBCT, we have teeth. In the STL file, we also have teeth. And based on that, we can match the files together. So it's a very simple protocol. But if you look on the CBCT scan on the left side, you'll find that this is a very clean looking CBCT. We don't have any artifacts. The challenge is when we have a lot of metal into the patient's mouth, this is when the challenges begin. And that's why we'll talk about how we can overcome the issue of metal scattering. Right now, especially right now, we need to make sure that we become as efficient as possible. Back in the day, if we have cases like this, for us to get a better looking CBCT scan, we usually take off the metal into the patient's mouth and take any crowns in the patient's mouth to do a CBCT. But especially right now, we don't want to do that anymore. We want to find a solution that is a very easy solution, and it's a very efficient solution. That's why we'll talk to you about the R2 tray. The R2 tray has been there for quite some time now, but it's still a very valuable tool. And what the R2 tray is a short tray, and basically what allows you to do is it just allows you to have a radiopaque marker in the CBCT. This tray is made out of radiopaque material. So that's basically the concept behind it. So when do I use the R2 tray and how do I actually prepare for it? So in a case like this, where your patient has natural teeth into their mouth, they don't have a lot of metal, they don't have a lot of missing teeth, there's no need to use the R2 tray. Just go and do a standard protocol. It'll make your life a lot easier. But if you have cases like these where you have a lot of metal into the patient's mouth, we definitely recommend that you do the scan with the R2 tray to make sure that you have good matching and for you to have a seamless workflow. So let's see how the R2 tray works together. Let's go ahead and see how we actually use this clinically. One second. Chris, so in Romania, for instance, do a lot of people use the R2 trays?
Yes, it's a standard procedure. And what I wanted to add is that because it's a standard tray, if you have some interference, you can trim the tray and customize it for your patient. So it's not a problem. If it doesn't fit exactly, you can make it fit better. And then you can use materials like occlusion materials, but don't take an impression. Just put a little material. We don't want a big material, quantity of material in this tray. And
so basically what you're saying is just the key is to control how much material we're actually putting in the tray. So we need to minimize the amount of material and use good material for our space.
yes,
correct?
Because after we have to scan it, and if it's too much material, I have to trim it, and then I have to, and I am not able to scan inside of the tray. So it's just a reference for the same position in the patient's mouth when he makes the CBCT and then on the model.
Excellent. So let's see how we use the tray actually clinically. So this is how the tray looks like. And again, as we said, it's a short tray. It's short vertically, so it doesn't cover all the teeth. Again, because it's not meant to take a full impression. So we just test the tray in the patient's mouth and make sure that it's, it fits really well. We train the patient on how to use it. We apply a little bit of adhesive into the inner surface of the tray, just like what we do with normal PVS impressions or rubber-based impressions. We load the material with the tray with material, whether medium body or even light body consistency material, or even a bite registration material, which is actually the material of choice. So here we put the tray into the patient's mouth. We seat it all the way down and just basically wait for the material to set. Wait for the material to set and then take out the tray from the patient's mouth. And then what I'll do in this video is we'll put the tray back in the patient's mouth, because we want to make sure the tray seats really well in the patient's mouth. And then after we do that, we send the patient to be CBCT scanned, whether in our office or in a training center. Now, the good thing about this tray is even if you have really bad scans, like this scan that we have in front of us right now, well, what would happen is now, even though you have a lot of scatter, as we said, but you still find and you still see the outline of the tray, and it really helps you with the matching process. And it gives you the most accurate matching, even in the worst cases possible. So that's why we recommend using the R2 tray. Now, let's just summarize and say when do we need to use the R2 tray. So again, as we said, if you have natural teeth, no need to use the tray. It's quite simple. But Chris, in cases where we have a lot of scatter, this would be the best case to use the R2 tray, correct?
Yes, this is a great tool. And it's the same principle also for the full edentulous cases. We need to create something that is individual. And in this case, we need to use a radio-opaque light curing material. And in order to register the occlusion and create individual marker. So if we use if you can show the radio-opaque material, the light curing radio-opaque material.
Definitely. So as you said, Chris, the idea for fully edentulous cases is pretty much the same. The same protocol is the only problem with fully edentulous cases is that in the CBCT of the patient, we don't have any teeth, right? Yeah. And if we take an impression inside the patient's mouth, we can only see the soft tissue. So there's really no reference for the matching. But if this is the case, how can I actually match the case? It becomes really difficult. And that's why we say that in fully edentulous cases, if your patient doesn't have a denture, so let's start with this. Let's say a patient comes to your office, they want to have implants, but they don't have a denture. This is the protocol that we do. So Chris, please tell us exactly how does that work?
So we need to have the impression with custom models, and then with this light curing material that is radio opaque, and it's very important because if this is not radio opaque, then we're not able to do the merging. So we put the tray on the model and we create a wax rim. The wax on top, the rim on top, it doesn't have to be radio opaque. It's just so the clinician can be able to register the occlusion. And once we've done that, we can send it back to the clinic and you can show on what happens next.
So basically, as Chris said, we always start out with taking impressions, and then what Chris will do, again, this is just as a reminder, this is for patients that don't have any dentures. We'll send that to Chris. What Chris will do is they'll do the resin basing, and then they'll put just wax on top of this, and then they send it to us just to do a bite registration. Again, what we do with any bite registration, it's very simple. It's just we make sure that the wax gives us good labial fullness. We'll make sure that we have the proper vertical dimension of occlusion, just like what we do with standard dentures. And we capture the centric relation of the patient, and we mark the midline and the canine line. And that's very important for us to mark the midline and the canine line. And again, these are all things that we do in a normal bite registration process. And then we send that back to the lab. So what do we do when we do that, Chris?
Yeah, when we receive the models and the tray, the wax rim in the lab, then we start scanning. And it's important to scan these models in occlusion, but also, like you are showing in this movie, to scan the individual tray by itself. And I think you will show us why it's very important to have this scan.
Exactly. And again, the idea behind this is when I CBCT scan the patient, you can see right now that in the scan, this part right here, this is the base that the planning center has actually done for us. And it's a radiopaque base, so it shows in the CBCT scan. So based on this radiopaque base of the wax rim, now we could merge all the data together. And again, I'm just reminding you to put the markings that we talked about, which is the midline and the canine line, because again, the planning center needs that to do the wax up, and Chris will show us exactly how we utilize this information.
Yes, remember we're following a fully digital procedure, and we need to design a fully digital wax up. And that's why the wax rim needs to have the guidelines as indicators for the digital setup of the teeth. So the wax rim has a double function. It stands as a marker for merging, but also it gives us the references to make our virtual wax up and to do a top-down treatment. So basically, we're creating not only a surgical guide, but also a prosthetic guide. And you can show us what happens next.
So after Chris will design the digital wax up, and then we'll do the implant planning, and this is where we move on. So let's say, for instance, your patient has a denture. So we get a lot of patients that do have dentures, but they just want to have implants now. They're ready to move on with the next procedure. So if the patient has a denture, do I really need to do all this? It's a pretty it's a process that needs to be done in case your patient has none. So if your patient already has a denture, you don't need to do all this. And I'll show you right now 3 alternative methods. If your patient has a denture, you could do one of them, and then based on that, you can start to do your guided surgery. So let's talk about option number 1, which is what we call the dual scan protocol using composite markers. So flowable composite is one of the things that we all have in our offices. All you need to do is just get the denture of your patient, add 3 to 4 markings on the buccal side and 3 to 4 markings on the lingual side. And based on that, because composite is actually radiopaque, I could just, after I do that, I can scan it with an intraoral scanner if I have an intraoral scanner in my office. Or I could just send it to the lab. They can scan it with a model scanner. Or I can even CBCT scan it, and eventually the result that I get is this. So I have the denture, and I can see the radiopaque markers in it right now. Now it's time to scan the patient wearing that denture that has the markings in it. So when I CBCT scan the patient with the markings, this is what I see. I see the composite markings, and based on that, I can merge all the data of the patient together. So the denture will act as 2 things. Number 1, the denture will help me plan things prosthetically, and the fitting surface of the denture will act as a model that I'll use in order for me to also fabricate my immediate restoration. So that's basically the idea behind doing this dual scan protocol, which is option number 1 in case your patients have dentures. Option number 2 will be to duplicate the patient's existing denture with radiopaque material. Radiopaque material like barium sulfate, for instance. And here, this is the same denture. If the patient is happy with his denture, it just duplicated with radiopaque material. And again, it will help me do the matching because it serves the same function. It's nice and radiopaque. And I also can see the teeth information. So based on that, I know exactly where to plan my implants. So again, it's a very easy protocol. The third protocol will be to use a reline of a radiopaque impression material, rubber-based material. Like in this case, on the left side, this is just a simple reline using PBS material. The only feature that this material has is that it's actually radiopaque. So it gives us a really nice indication on where exactly is the soft tissue, and it helps us with the matching process. And in some cases, you could use what we call a radiopaque spray. I know this is not the most famous method, but it's actually there. And some people could use just a radiopaque spray. They just spray that in the fitting surface of the denture, and then they CBCT scan the patient. So how does that look like? This is basically how it looks like. Because it's radiopaque, whether the impression material we're using is radiopaque or the spray itself is radiopaque, you see a really nice demarcation line, and this is what helps us match everything nicely together. So again, right now we covered all 3 different protocols that we could use in case your patients have a denture, just to save ourselves time and become more efficient.
I'm glad you explained all this, Sam, because doctors need to understand this before they send it to the planning center. So I'm really glad you did it.
Agreed 100%. And I do believe that this is the responsibility of the dentist, not the responsibility of the lab. We as dentists need to know what type of cases we're doing, and we need to know which type of scanning protocol we need to use for that particular case. So right now, let's go ahead and talk about execution. We talked about efficiency and planning. Let's move on to execution. Now I'm doing, and now I'm applying what I actually have done. So when it comes to execution, what we always recommend for you to get good results and to get exactly what you planned for without any deviations, without any major changes, use a surgical guide. A surgical guide will make your life easier. And a lot of people will say, if I have cases like these where I have plenty of bone, do I really need a guide to do surgery here? And actually, you don't need a guide to do the surgery because the surgery might be easy. But I need to change the way people think. Right now, we're moving into shortening the treatment time, especially right now. So we can only do that by going in with what we call prefabricated prosthetics. So if we go in the surgery with the prosthetics, this prosthetic will only fit in one position. And the guide will help us put the implant in that position where the prosthetic will fit. So this is what we call the restoratively driven planning, a planning guided prosthetics concept. We're not guiding the surgery, we're more guiding the prosthesis. And this is what we want to do. This is how we're serving our patients, and this is how we're becoming more efficient. Now that we mentioned this, let's talk about the rise of the one-day implants concept. The rise of the one-day implants concept, a lot of people are doing one-day implants right now. So many people, they call it different names, same-day teeth, new teeth in one day, new teeth in a day, all different names, but it's essentially the same thing. The patient comes to your office and they leave with teeth. The only difference is now is how long does that process actually take? And what I always say is there's always the best way to do something. So ideally, for us to do the one-day implants procedure in the most efficient way, we have to, get these 3 criteria. Number 1, this process needs to be done where we replace and restore the implants in the same day. And ideally, we do this in a digital way. Number 2 is all planning and manufacturing of prosthetics should be done before the surgery to minimize chair time. And that's the most important part. You have to make sure that whenever you plan the case, you plan it beforehand. And when you manufacture the prosthesis, don't do it chair side. If there's a way for you to do the prosthesis before the surgery, do that, because that will save you a lot of chair side time, and chair side time is the most valuable time. And number 3, this process requires very careful treatment planning and consideration to all aspects of treatment. So let's focus on the all planning and manufacturing of prosthetics should be done before the surgery part. So Chris, how is it exactly that we can design a prosthesis before the surgery?
Well, after the treatment planning is done, and I want to say that the planning should always be checked or supervised by the medic. Then we can export the model with the scan abutment, and it's like having a model with the analog of the implant. And based on this model, I can start my design in a specialized third-party software like ExoCAD, 3Shape, and so on. So with this scan abutment, I can start designing on my provisionals, and I can also I can export not only the scan abutment, but I can export also the stock abutments and have an idea about the cuff height or the diameter of the prosthetic that I want to use. And I can also export a multi-unit, the position of the multi-unit, so I know the angle of the multi-unit and the height. So now we have a great tool for prosthetic planning and manufacturing, and all this is done before the surgery. So you can choose now, Sam, between the provisionals that you want to have.
Definitely, and I would definitely prefer to do to get a prefabricated restoration that takes me a minute to fit in place than to do a chairside reline, and that is actually a very time-consuming process. But what different types of prosthesis can we do with this protocol?
We can have a screw retain restoration, where we design and then cement the crown directly on a prefabricated titanium base. And again, this is all done before the surgery. Or if you're a fan of the one abutment, one time concept, we can design a hybrid zirconia abutment and cemented restorations. If you don't like the hybrid abutments and you want more strength for the abutments, you can use a pre-mill to design a customized titanium abutment and with cemented crowns. We also have solutions for full edentulous where we are using multi-unit abutments. And because ArtGate allows to export the model with the multi-unit, we can design a full arch bridge for the pickup. So this way we can obtain a fixed and passive provisional, but I think you can explain more of that.
So the idea behind doing the prosthetics before the surgery is actually a major time saver. And I think for me to receive from the planning center, you know, from my ArtGate planning center, to receive this data right here, to receive a surgical guide with a prefabricated prosthetic, all I do basically in the surgery is to just place my implants and I just do the pickup in the patient's mouth. And this is the most passive way for your prosthesis to fit really nicely. And now that we talked about the fact that immediate loading or one-day implants is what we should be doing, we shouldn't just jump into doing immediate loading. What we need to know is we need to know if immediate loading is actually safe to begin with, because this is a very hot topic right now. And I believe that for us to actually give such a decision, from my point of view, I would say immediate loading procedure is absolutely safe, but if done properly, and it's really important for us to understand what does if done properly mean. So everything in the world needs to have criteria. For you to know that your immediate loading is safe, we always have to have guidelines. So the guidelines for this is by using the two most objective methods to assess implants' primary stability. That would be insertion torque and ISQ. So how can these tools actually help us make good clinical decisions? And that's what we'll talk about right now. So we have three different clinical scenarios that we might face. We have the single restoration, we have the multiple restoration, if in case we have a bridge, for instance, and we have full arch restorations. And each one of those has a slightly different criteria. If I have a single restoration, if I place the implant with 45 Newton centimeter and I get 75 ISQ and it's a single restoration, I can actually load this and I can place the crown in the same day. And it's considered safe immediate loading. On the other hand, if I have a bridge and I place the implants in that bridge with 40 Newton centimeter and 70 ISQ, I could load the implants as well. Now, the third clinical scenario is full arch restorations. If I get 30 Newton centimeter for all the implants that I place in a full arch restoration, and I get 65 ISQ, I could do immediate loading. And if you notice, you'll find that the numbers are actually going down. So we went from 75 to 70 to 65. And we went from 45 Newton centimeter to 40 to 30. And the key is splinting. Splinting is what actually helps our restoration survive. So the more implants you have, and if you have what we call cross-arch splinting, so if you have implants on both sides of the arch and you splint all the implants together, your immediate loading procedure becomes more safe and it becomes more predictable. And that's very, very, very important. Nevertheless, I need to remind you guys that not in all cases we get the numbers needed to do immediate loading. So sometimes we're not that lucky. So what about the cases where we don't get get these numbers, what exactly do we need to do? So if we said immediate loading allows us to be more efficient, if it's done safely, how can we still be efficient if we don't get the numbers? So let's talk about that. So using devices like ISQ, for instance, actually help us make good clinical decisions on what to do. So for instance, we could actually know how to schedule the patient recall appointments scientifically and efficiently. So if the patient comes today, I place the implants for him and I don't have the numbers to do immediate loading, when exactly do I bring the patient back? I don't want to bring the patient back too early, and I definitely don't want to bring the patient back too late. So how can we do the recall appointments in a scientific and in the most efficient way? What I recommend doing is I recommend following this particular graph. Let's look at it from the right side first. We said if we have high primary stability above 70, we could do immediate loading if you have a single case, for instance. So, or we can even do one stage. One stage meaning that we place the implant and we place the healing button. If you don't want to do immediate loading, that's fine. But you could do one stage. Now, if you get 65 to 70 ISQ, you could do one or two stage and you could do early loading. So what does early loading mean? For instance, if we're talking about any rigid implants, we could do a 4-week or 6-week loading protocol. So I could bring the patients back after 4 or 6 weeks to get their impressions. I can bring them after 4 weeks to take an impression and load after 6 weeks, for instance. And that will make my life a lot easier. And now, again, the patients don't have to wait for 3, 4, 5 months unnecessarily. And that's because I have a guideline that is ISQ. Now, let's talk about cases where we get from 60 to 65 ISQ. In these cases, these are the cases where you should do 2-stage. So you have to bury your implant and you do traditional loading, which means that you wait a little bit longer. Maybe with our any rigid implants, we'll wait for about 3 months. So that's basically the idea. And that's how we become more efficient when it becomes, when it's time to reschedule the patients. Again, for low ISQ like 60, you definitely have to monitor your implant because this is quite low stability. So again, ISQ is an extremely valuable tool that will make us get good clinical decisions. Now, again, to our main topic, I don't want to go too far from the main topic, which is efficiency. Now, we talked about efficiency in planning. We talked about knowing the right data to acquire and checking the data. We talked about understanding the scanning protocols. We talked about efficiency in execution and how guided surgery will actually help us do that, and how we could do immediate loading using prefabricated prosthetics. Now let's talk about efficiency in follow-up. How can I be more efficient even in my follow-up? If the patient comes back, how can I be very efficient? Well, I'll refer to the same question that my good friend Marcus Ingolstadt always asks in his lectures. He says, how many times do we screw things on and off the implant from placement until restoring the implant? So if I place the implant, if I do 2-stage, so if I do the implant with a cover screw, I then have to bring the patient back to get the healing abutment, and then I have to bring the patient after a while after the gingiva has fully formed, and I have to place one of those impression copings, and then I have to bring the patient back for a try-in or for a final delivery. So basically, if we do 1 stage, we have to remove things on and off the implant 7 times. And we're removing things and attaching things, removing and attaching things. If we do 2-stage approach, we do that 9 times, and we can actually count it together. So maybe there's a way for us to actually become a little bit more efficient. And I think, Chris, we need to find a way for us to actually become more efficient. And actually, by the way, from a clinical standpoint, it's not good to keep removing things on and off the implants, because according to Abraham, and what we found is removing the healing abutment, especially the healing abutment on and off the implant multiple times, and this disconnection disturbs the attachment between the soft tissue and the abutment, which eventually leads to bone loss. So that's one of the things that we really need to consider. So how can we minimize the amount of screwing things on and off the implants? So Chris, what do you think? How can we do that?
Well, we have a solution, and it's a great smart digital product. It's called the Scan Healing Abutment, and it combines the healing abutment and the scan abutment, so you don't longer need to remove the healing abutment when we want to scan the implant. By using this product, we can connect directly to the healing abutment and proceed with the scan. And from my point of view as a technician, I think the scan healing abutment helps me very much, because I don't have to worry so much about the critical and subcritical contour of the emergency profile. And the provisional will copy exactly the shape of the healing abutment. It's just another perfect example of copy-paste dentistry principle. I think you agree.
I agree 100%. And I think it's also easy to use clinically, correct?
Yes. So just have to place the scan abutment, the scan post with the carrier, and proceed with the scanning and send it to the lab digital.
Excellent. I think this is a very, very smart idea, and that allows us to actually, as we said, just do the right thing and minimize the amount of time that we actually have to spend in the office. So this is a case of my great friend, Dr. Marcus Ingolschalk. He sent me this beautiful, beautiful case that shows how exactly we use that scannable healing abutment, or SHA. So this is a case where we're missing the second premolar. This is how the case looks like. And then what we do is we do our standard surgery. If you want to do it guided, if you want to do it freehand, do it however you would like to do. But the concept is attaching this type of abutment, rather than, if you get good eyes cue that actually allows you to do one stage, instead of using your standard healing abutment, use the scannable healing abutment and attach it in position, and then just let the patient go. And that's basically how the scannable healing abutment looks like. Wait until everything osseointegrates. Wait exactly how much time the ISQ tells you to wait. And in this case, we actually didn't wait for that long because we got good ISQ. So we did early loading. In this case, we brought the patient back after a month and a half. And this is how the patient looks like. And this is how the healing looks like. Now, the great thing is I don't need to detach this abutment. All I can do right now is I can get my cap, my scannable cap, and just clip this on top of the healing abutment. After that, I could just scan it very easily. And then when I scan it, I scan the upper, I scan the lower, I scan the occlusion, and I just go ahead and send it back to my lab. And again, imagine how much time this actually saves you. Removing the healing abutment, attaching the impression coping or the scan body, taking an X-ray to make sure that it seats down all the way, and then removing it, or doing the scan and removing it again, and having to deal with collapsing of the emergence profile. As Chris said, this type of abutment, besides the convenience of it, it actually helps us maintain the same emergence profile, and we don't have to be in a hurry. So that's the good thing about using these abutments. Again, we sent everything back to the lab. The lab will design the prosthesis for us, and all we have to do is just place our prosthesis. And again, imagine we only had to deattach this abutment once at the time of the final restoration. So again, one abutment, one time. And that's pretty much all we need to do. So in the presentation today, we covered how we can become efficient in implantology. I think we covered basically everything that we need to know. We have to, what we said is, ideally, let's use digital planning. Let's use guided surgery. Let's use immediate provisionalization. And let's use devices like ISQ that help us make good, proper, and good clinical decisions on whether to do immediate loading, whether to wait and not do immediate loading, and exactly how much should we wait in order for us to be really efficient. And in order for us to have the most convenience, we came up with the smart digital tools like the scannable healing abutment, which will definitely support the biology, and it will also help you be more efficient, and it will save you a lot of time. So that's basically what we wanted to tell you today in our presentation, that using such digital devices and doing digital planning, doing guided surgery the right way will help us free ourselves from complications and anxiety. To prepare is better than to repair. And that's really the key word of today. Chris?
Yeah, and also checking the collected data will save you a lot of time and will improve your digital experience.
I agree 100%. We have to always check our data before we send it to our planning center. And that's the key to save ourselves time and to avoid any repetitions. Also, we need to understand and choose the right scanning protocols. Just like we choose the treatment for our patient, we have to know that different patients, different cases have different scanning protocols. So that's the key to avoid unnecessary repetition of scans. Chris?
Yeah, we can do the we can prefabricate prosthetics, and this will also help us reduce the chair time and increase the efficiency.
Absolutely, and also to transfer the data digital between the lab and the clinician will actually, that's if possible. If you have an intraoral scanner, that would be fantastic. That will help us, save time and also promote safety. So that's also, a very, very, very important thing to mention. And using digital devices like ISQ help us know the right time to schedule patients back for recalls and impression appointments. And last but not least, smart digital tools like scannable healing abutments can help promote biology and reduce scanning and chair time. With that in mind, we just want to thank you so much for listening to the presentation that we had today. I hope that it was nice and informative. We also want to remind you to stay safe. And for us clinicians, we always need to wear our PPE. So wherever you go, wear your PPE and try to stay safe and always be committed, no matter what happens. Thank you so much.
Thank you, Sam. Thank you, Cristian, for your really outstanding presentation. Everything was really clear that even I understood, so that was really awesome. So we have received several of questions, so I would like to move forward with it. So talking about the concepts of one-day smile and one-day implant and everything like that. So most of the questions stays the same, talking about the all-on-4, yeah, because it's the most common thing when we're talking about one-day smile. So the question, when we're talking about the bone reduction, yeah, how to manage that situation. So do we need to make another guide? Do we need to make 2 or 3 guides extra, or how to do that?
Okay, so with bone reduction guides, all you need to do is, what you have to make sure that number one, you have a good prosthetic reference, because you need any way to know exactly where you're planning your implants. So that's the key. And as far as the different types of bone reduction guides, we have a lot of different types. We have the stackable guides and we have the sequential guides. So sequential guides means that you place a guide at the beginning, you take that guide off, and then you go ahead and do another guide to do the implant placement. So that's what we call the sequential guide. On the other hand, what we call a stackable guide is a frame, is a main guide that you use to do the bone reduction. And on top of this guide, you use different guides and you stack them on top of each other. So these are all different ways that we could do that. And right now, together with Chris and together with the guys back in Estonia, we have stackable guides that we could use that are very compatible with R2 gate. So you could do your bone reduction, number one. You could do your implant placement, and you could do the prosthesis all in the same day. So that's a very nice protocol.
Yeah, we can actually, it is possible. So we can make the bone reduction guide, but we need to use another software beside the R2Gate. So this is the difficulty right now, but we're working on it to be able to do it in the R2Gate software.
Yeah, perfect. Also, we have Mr. Nuno Gaspar. I think you know him. And he's ready to chat with you. Yeah, because he has several questions to ask. So you are permitted to talk, and Nuno, go ahead.
Hello, my friends.
Nuno, how are you?
For this wonderful lecture.
Thank you so much.
I congratulate you both.
Thank you so much.
I wonder what kind of VPS you use when you use a denture to realign it and do the CT scan. Because I tried some and I don't get that radio opaque image that I wanted to. And Chris knows that.
So for instance, in our cases, I use Zermac, and actually light body Zermac actually it gives you a little bit of radio opacity that will help match everything together. So for me, for my experience, using Zermac light body consisting material actually allowed me to do that really well. So that's what I recommend using personally, and that's what really worked for me.
Okay, and what kind of spray is that you used?
Okay, so I had this very interesting meeting with Dr. Dick Cleaner. He's from the Netherlands. And he showed me this type of spray, which I actually have right now in my office. It's a very interesting type of spray. This material, all you need to do is just spray it. Let's say, for instance, if you take an impression, even if it's an alginate impression, if you just spray the inside of the impression, it gives you a very, very thin radiopaque layer, and it gives you this, it helps you distinguish the surface of the soft tissue from the impression. And it really helps with the matching process.
But it's only found in the Netherlands, this spray?
I think so. And I think if we, you know, if we really find that this is a very good technique, I think we could make this an official product, and we can speak to Dr. Dick, and we could actually help us use this, because in some cases I used it. He told me at the time, at the beginning, he said the key is to control the amount. So right now I'm still experimenting with this type of material, and by time I'll get a grasp of exactly how it works, but it's still a very nice idea. So hopefully we could start to use it a little bit more.
Yeah, thank you. Thank you, guys.
Thank you so much, Nuno. Thank you so much.
Look forward to see you all soon.
Same,
as soon as this pandemic goes away.
Absolutely the same.
All right, guys. So we don't have any questions left, but if some guys from the attendees would like to ask something, so you are ready to go. Have your chance.
I hope that that everybody really benefited from this, and I hope that now that we're coming back, I hope people come back with a positive mind, because I know we went through some tough times, and believe me, everybody went pretty much through the same process. So I just hope that when we come back, everybody stays safe, and we become more careful, and hopefully we start to think about things in a slightly different way. Not completely change the way we're doing things, but always bear in mind that we could be a little bit more what can we say, effective. That's the key word. Be more effective, and see what we've been doing before and how we can save time by doing and utilizing other technologies and other things that would definitely help us in the process of becoming most efficient.
Yeah, I think these online events are a great tool, because we can all have some ideas, and when we go back to work, we can start practicing some of these ideas. So thank you, Megagen and Minek, for this opportunity.
Thank you.
Absolutely.
Thank you, Cristian.
Absolutely.
Thank you, Sam.
Thank you so much, Rolandus.
No problem. This was really my pleasure. And the next Megagen webinar will be held on upcoming Wednesday, on May 20th, when our guest speaker will be worldwide known Dr. Howard Gluckman, with the topic creating ideal soft tissues around the implant. So
lucky people.
Yeah, so I'm really excited to have him here on our stage, and I hope that all of you guys will attend his webinar as well. So once again, Cristian and Sam and all the attendees, thank you so much for attending this special webinar, and hope to see you soon on our next one. Yep. All right. Thank you, guys. Thank you. See you soon.
Bye, everybody.
Stay safe.
Have a nice day.
Bye.